Yeah. Well, thanks everyone for joining today. The title of my presentation is Supporting Intergenerational Wellness and Resiliency Using a Whole Health Approach, Multiple Pathways to Change. My name is Christine Garver-Apgar. I am an assistant professor here in the Department of Psychiatry, and I'm the Research and Evaluation Director for the Behavioral Health and Wellness Program. And so I'm really happy to be here presenting to you today on a program that we've been developing and working on for just a long time. It's been a long road, so I'm really happy to be and excited to be presenting some results and just kind of how these demonstration projects have gone. And I also don't have any conflicts of interest to disclose today. And I thought I would open with just by sharing a quote from a participant who completed the program that I'm going to be talking about today. This was during a focus group, and she said, "I realized that I was not the only one with chaos at the house. I realized that we all go through similar things as mothers. We're all tired, we're all stressed. I learned in this group to control my stress, relax with tea, that we need to go to sleep earlier and get at least 8 hours of sleep. And so everyone at the house started to do that. I started at first, and then everyone continued after me. In the morning, everyone is more relaxed and with no stress because everyone had rested enough. It's honestly also helped with the way we understand each other. Instead of being on our phone or tablet, we started going to the park and doing more family activities. Honestly, I've learned all of that in the group, and I'm very thankful because my life has changed for the better." And so I think this sort of captures for many of us, those who work in these types of spaces, why we do the work that we do, and also, of course, why we're here today. So today, what I would like to do is describe the rationale of the program, and the structure and the curriculum itself, so that you can see a little bit about what the program is and what it looks like. And then I'll present some initial findings from the Raise Families for Health pilot initiative at a few different sites that we've been doing for the past couple of years. And towards the end of the presentation, I'll discuss some challenges and solutions for successful program implementation and evaluation. All right, so we'll start with some information on why we developed this program and what we were aiming for and what it looks like. So we know that poor health and chronic disease tend to run in families for lots of reasons. Factors like genetic predispositions, engaging in similar behaviors that increase risk for developing chronic disease, environmental factors like the availability of nutritious food and stress, that in turn can actually change how genes are expressed, is something that researchers have started to learn more recently. And we know that priority populations are especially likely to struggle with attaining healthy lifestyles. So people living in poverty, those experiencing racial discrimination, those struggling with behavioral health conditions are especially vulnerable when it comes to experiencing the burdens of tobacco use, managing stress, maintaining healthy sleep, nutrition, physical activity. And so all of these challenges place priority populations at greater risk for developing chronic diseases and other health problems. And so we set out to develop a program that would tackle the intergenerational transmission of poor health and disease, and paying particular attention to closing health disparity gaps, which means paying particular attention to the accessibility of the program to priority populations. And for parents living in poverty, raising children in developmentally supportive environments is particularly stressful. The challenges of providing nutritious meals, supporting physical activities, ensuring adequate sleep, that all takes an emotional toll on parents who have limited resources and support. And the stress is magnified, of course, when parents are, for example, raising children alone, when they're working non-traditional jobs with non-traditional hours, or when they're struggling to obtain safe and nurturing childcare for their children. And, I probably do not have to mention the additional burdens on parents brought on by the pandemic, which really has made all of this work seem especially relevant and salient for everybody involved in these projects. So based on this knowledge, we wanted to integrate whole person wellness into the curriculum to directly address these family-centered barriers to creating healthy lifestyles. And we wanted to design a manualized program that had health literacy and family-based SMART goal development activities, because we wanted to bolster engagement and help families really take pragmatic steps toward health behavior change. We also wanted a program that was person-centered and that it meets people where they're at and supports their readiness for change as they identify their own individual wellness priorities. A whole health perspective is inherently person-centered because it allows for choice and flexibility when thinking about what a healthy family looks like for each individual person and what goals a person wants to focus on. And then finally, attending to multiple wellness domains allows individuals to develop more generalized motivation, coping skills, and self-efficacy. Individuals may not choose to start their wellness journey with a focus on something that a healthcare provider or a friend or a family member might think is that person's most pressing need. But by allowing people the space to build confidence and making changes in other areas, they are often motivated to continue taking steps in other wellness domains that are potentially more difficult for them. All right, so the goals of the program. Ultimately, we wanted to interrupt the intergenerational cycle of poor health and disease among vulnerable families. We wanted to provide administrators, healthcare providers, and peer specialists the knowledge and skills to support caregivers as they work towards sustained health behavior change. We wanted to promote positive behavior change through motivational engagement and behavior change strategies. And we wanted to create a positive social network for parents and caregivers to build awareness about the importance of healthy lifestyles and support their wellness goals. Now, I want to come back to this quote because I think it illustrates some of what we were hoping for with the program. The first sentence illustrates here the support that she was feeling from being part of the group. She realized I was not the only one. We're all tired. We're all stressed. Here she identified a goal that was important for her family, and that was dealing with stress and getting better sleep. So this was something that she personally identified that they were going to work on. And then here, this nicely illustrates the idea that if parents make healthy changes or caregivers, beneficial impacts for the family often follow, either directly, as was the case here, because the family actually changes their behaviors as well, or simply indirectly because parents who take care of themselves are, of course, better able to take care of their families. And then finally, she alludes to the fact that one benefit, better rest and lower stress, has led for her to other benefits, less sitting around on devices and more physical activity. And so this illustrates the effectiveness of multi-domain interventions and the idea of there being multiple pathways for change. And I want to say just a few words about integrating tobacco treatment and prevention into a whole health intervention. The demonstration projects that I'll be talking about today, the main one I'll be talking about today, was actually funded by the Tobacco Division of the Colorado Department of Public Health and Environment. And the rationale is this. So we know that effectively reaching and providing tobacco cessation services to health disparity populations is just a perennial issue. And at the Behavioral Health and Wellness Program, we've been long making the case that a promising means of reaching some of the most at-risk smokers is to integrate cessation services into a whole health intervention. Tobacco cessation is a really great example of something that people may not choose to start with, particularly if it isn't why they joined the group focused on a healthy lifestyle, or if they're not considering quitting. But they will often build confidence and motivation to consider tobacco treatment as they work on other wellness dimensions. And so for those with complex needs, a broad focus on health behavior change has unique benefits that do extend to tobacco cessation. And creating buy-in from people by integrating tobacco education and treatment into a whole health program, more broadly focused on creating healthy families, is really what we're going for here. The idea that we're targeting families for this intervention makes this an even better strategy because parents are more likely to consider the family's tobacco use and environment for the health of their children, even if they aren't ready to quit smoking themselves. And that opens a door. And in addition, non-smokers can also benefit from these kinds of discussions because, and by remembering that just because they may have a tobacco-free household, that doesn't mean that they can forget about prevention when it comes to nicotine addiction because they're raising a family. And finally, we know that tobacco use often carries stigma. As nicotine addiction and tobacco use become less prevalent, the unintended consequences are that for people who do still use tobacco, there's an ever greater stigma. And so by approaching tobacco treatment through sort of a side door of general health and wellness, the treatment stigma may in fact be lessened. All right, so what is Raise Families for Health? Well, briefly, the program includes a comprehensive 2-day staff training, which is flexible and can be accomplished in multiple ways. It includes a manualized curriculum and materials to run an 8-week group for parents and caregivers, and it includes materials and technical assistance for program evaluation. So a little bit about the staff training. It covers scientifically up-to-date information on each of the things listed here: stress management, sleep hygiene, nicotine addiction and tobacco treatment, nutrition, physical activity. It also includes training on motivational interviewing strategies for enhancing individuals' commitment and motivation for change. And then it includes training in how to actually run a parent group and the materials needed for that. One central feature of the training is that it is tailored to specifically address the needs of low-income parents and caregivers. So for example, the training for professionals who will be working with families highlights the unique sleep and nutritional needs of developing children and the potential lifelong consequences of children experiencing toxic stress, for instance. The tobacco cessation portion and the group curriculum would emphasize potential familial transmission of tobacco use problems from parent to children and risks associated with secondhand smoke, both in the household and family vehicles, and ways to alleviate these risks, like how to work with families to encourage the adoption of smoke-free homes and vehicles. So these are just some examples of how we've tried to tailor the content for parents and caregivers. So I've talked a lot about families, but notice that the target of the program is actually parents and caregivers. And we know that helping parents create healthy behaviors and routines ultimately helps the rest of the family to do the same. Multiple members of a household are invited to participate, and that reflects all kinds of different family structures for raising children that we know particularly priority populations make excellent use of. And then activities are designed to help participants identify links between their own health and wellness and their family's health and wellness, and how improving one impacts the other and vice versa. Participant-facing group materials and also evaluation materials are available in both English and Spanish. The program can be run either in person or virtually. That's thanks to the COVID pandemic. We did a pivot, and so we can now offer the program virtually. That's actually been quite a positive development for the program, as you'll see. The program can be run either in a group-based format, as I've been talking about, but the session materials can also be used one-on-one, depending on the needs of the organization, where a facilitator would just work through the session materials with a single person. And then the program is generally facilitated by trained personnel housed at the participating organization, rather than by outside facilitators. Although I should note that there are a variety of models that could be explored. So for example, some organizations might want to consider an academic partnership in which trained residents or fellows are placed at an implementing agency or a clinic for internships, just as one example. So just to briefly walk through these topics, there are 8 sessions. The first session really just helps participants define for themselves what it means to raise a healthy family and envision their ideal family. The second session is designed to help participants understand the concept of behavior change and what it takes to change behaviors. So they learn how to set goals that are specific, attainable, realistic, and timely. Oops, I forgot measurable. So those are SMART goals. Group members explore how triggers, habits, and rewards shape their behaviors. And they learn how to identify new habits to replace old ones. And then each of the other sessions focus on a particular topic. Participants evaluate themselves on the topic. So for example, they might evaluate their own stress levels, and they learn about the topic. So how to manage stress, for instance, and why that would be important for their health. And then they would, in each case, they would set their focus and develop a goal related to that week's topic, along with the reasons for making a change and potential challenges and strategies for making the change, and also their strengths and resources for change. And then lastly, the last session, I'm going the wrong way. The last session explores ways to support participants in their change process beyond their participation in the group. So group participants would reflect on their experiences and progress throughout the RAISE program, and then they continue to envision their healthy family. And then here's just a couple of examples of what the participant materials actually look like. So this is from the Coping with Stress session. They get to choose kind of a direction where they would like to start. They get assistance helping to set a goal, and then what they need to set their goal through these different worksheets, and then the reasons that are motivating for them to change, some challenges and strategies, and then again, strengths and resources. All right, so now I'd like to turn to a summary of the demonstration projects that we've been carrying out over the past 3.5 years. And this is a busy slide, but I'm going to walk you through it. It gives an overview of the grant-funded work that I'll be talking about at 3 different sites in Colorado. Essentially, there were 2 main demonstration projects, one of which took place at Sheridan Health Services, which is the first one that's shown in green, and then one demonstration project in Larimer County, which was funded by Larimer Behavioral Health Services. And that one took place at 2 different nonprofit social service agencies in Fort Collins, and it's shown there in blue. And the scales are actually not the same. The Sheridan project has lasted 3.5 years, whereas the Larimer project has taken place entirely within the scope of 1 year. I'll go over these briefly so that you have just a general idea of the process here, but we'll talk more specifically about each of these things as we go through the presentation. So essentially let's start with the Sheridan. There was a kickoff meeting that happened. Everything started in July of 2018. This grant allowed us a really nice program development phase, which took place for the most part of the first year of the grant funding. Staff at Sheridan were trained over the summer of 2019. And then marketing and recruitment started. And I will say, marketing and recruitment really started towards the end of the summer, I'd say into September. Recruitment at Sheridan was really hard. Months went by without any groups being run after the staff training, despite a really concerted marketing effort. After a couple 2 full months, we then expanded the eligibility criteria in November. Initially, we were recruiting parents or caregivers of young children from households in which someone was using nicotine or tobacco, because keep in mind, this was funded by a tobacco division. And however, we expanded the eligibility requirements to include non-tobacco users and everyone with a child in the home, regardless of the child's age. And then about 6 weeks later, we secured additional funding to implement an incentive structure as well. So by January or early February of 2020, we had all of those pieces in place. And the new criteria had been communicated to the Sheridan staff and providers and community partners. And we successfully recruited for our first group, which happened right here where the star is on March 13th of 2020. And I remember that date very well. Many of you might as well, because that's the first day my kids were home from school on account of a pandemic that started closing things down, including the Sheridan Clinic. So our first and last on-site Raise Families for Health group was run on Friday, March 13th. And at that point, we spent the next month or two pivoting to running the program virtually, which was really a good thing ultimately. And so this is all to say that marketing took a long time. It took a while to get our groups up and going. So groups were run from March of 2020 all the way through August of 2021 for the Sheridan project. Most of this data that I'm going to be presenting today do come from the Sheridan project, because the Sheridan project had a much more extensive timeline and initiative, and that they really had more time to build a culture of data around evaluation. But I am gonna come back to the Larimer demonstration project a bit later on in the presentation when I talk about the process of implementing the program. The key aspects here look very similar to Sheridan. They're just truncated into a much shorter timeline. All right. So a little bit more about the sites. Sheridan Health Services is a federally qualified integrated care clinic. It's entirely nurse managed. It's run out of the CU College of Nursing. They serve a predominantly low income population who, most of whom identify as people of color. A little bit less than half are best served in a language other than English. The mission of Sheridan is to provide an integrative model of care offering primary preventative health and counseling services to the community with a special emphasis on the underserved population. And then the other two sites were the Matthews House and the Center for Family Outreach. These are nonprofit organizations located in Fort Collins. I'll probably refer to them as our Larimer sites. They are two organizations that serve at-risk youth and families. They provide education, prevention, and early intervention programming for families facing poverty, abuse, substance use. So these are social service organizations that we partnered with through a separate grant funded by Larimer Behavioral Health Services. All right. So first, the project at Sheridan. Here's just a few details about the participants that we had. There were 66 participants total, 3/4 of which completed 3/4 of all the sessions. And I should note that initially when recruitment was still fairly slow, our facilitator went through the program with several people just on a one-on-one basis. And so if you're doing it one-on-one and you're doing it virtually, if a person misses a session, it's very easy to just reschedule that session topic for the following week, whereas you can't do that if you're doing it in a group. So if everyone had been run in a group, this number might not actually have been quite as high as it was. A lot of people finished all 8 sessions just because you can reschedule. So that's one benefit of doing a one-on-one program like that. 57% of our participants participated in a Spanish group, or they had the materials facilitated in Spanish. Almost all identified as Hispanic or Latino. All of them were women, except for one lone man who participated in a group. And 20% of the sample reported housing insecurity as defined by people responding yes to the item, are you worried or concerned that in the next 2 months you may not have stable housing that you own, rent, or stay in as part of a household? 28% reported food insecurity. I'm not going to define that. And then about a third of the sample, we asked what the highest level of education was for anyone in the household, and 33% reported that no one in the household had completed high school. So just some demographics about the sample. Participants completed surveys throughout the program that assessed relevant domains that were being addressed throughout the program. So in general, each week toward the end of the session, people would complete a survey that related to the next week's topic. So these really shouldn't be thought of as baseline indicators because they're assessed throughout the program and they're just assessed a single time, but they do help to sort of characterize the particular population with regard to the health behaviors that we're addressing. And this is just a sample of items assessed on these topical surveys. So 54% reported that they grew up in a household with people who smoked, and 42% indicated that they had been tobacco users at least some point in their lives. Although we had very few tobacco users actually participating in the program. About 41 to 46% said they get the recommended amount of sleep per night, which we defined as between 7 and 9 hours. And that just depends on whether they were talking about work days or weekends. And 54% reported some negative effect of poor sleep over the past month. They reported relatively high overall health on a scale of 0 to 10. Their nutrition habits weren't too bad. It was the case that almost 30% were often or almost always drinking soda or sweetened beverages, so some room for improvement. But they were mostly cooking and preparing meals at home. And a lot were saying that they were eating fruits and vegetables with meals or snacks. And then this was a fairly physically active group. They were not big sitters. Only 19% said they sit down more than 5 hours a day. They were also not big TV watchers, and they were not huge internet users. This was not a particularly technologically savvy population, so that may be why. But they only half were saying that they, got less than the recommended amount of physical activity per week, and about half were getting at least the recommended level of physical activity per week. All right. This is the personal progress form that we used for assessing change over time. So participants saw this form every week, and it's a brief form. They fill it out in just a few minutes at the beginning of every session. This is how we track just whether participants were making some progress on goals and on some of these health indicators that we've just been talking about. So I'll present data based on this form. You can look at this on your own if you're interested later, but this form is what I'll be basing some of the data that I'll be presenting next. All right, so how did people do over time from the Sheridan group? So in terms of sleep, they did make some improvements. They went from 6.9 hours of sleep per night to 7.4 hours, which is a gain of half an hour of sleep. These are based on 40 participants. Not everybody completed personal progress form data, so I don't have forms from all of the participants. So what we're seeing here in each case is a person's score on something at their first session, and then what it was at their last session, whenever that session was. So for some people, they may have only attended 2 or 3 sessions, in which case the last session indicates maybe their second or third session. In a lot of other cases, it's their 8th session because they attended all 8 sessions. For stress, people, made small improvements. They went from a 6.0 on the scale down to a 5.4. So stress was reduced a little bit. And then food quality went from a 6 to a 7.1. So they did make some improvements in the quality of their diets over the course of the group participation. And then physical activity here is shown. In the interest of time, I'm not going to actually talk about the bar graph on the right, so just focus on the all respondents on the left. Essentially what you're seeing here is that at the first session, 55% of folks said they got less than 30 minutes of activity a day or none at all. Whereas by the last session, those two numbers had flipped such that the majority of participants were now saying that they were getting at least 30 minutes of exercise or more per day than at the beginning of the program. But again, the numbers are small here. We certainly weren't, this wasn't a research study. We weren't powered to detect significant effects necessarily. So I think what this would indicate to me is that the results are positive, and a better powered effectiveness study in the community would be a great idea. All right, and then during the final session, participants were asked to reflect on each goal that they had set during the program. And so for each one to answer 3 questions about it. The first question we asked them was, how much progress did you make while working on each goal? And the bars here show the percentages of people saying that they made excellent progress, good progress, a little progress, or no progress. And basically, just for ease of reading, green and yellow bars are excellent and good progress. So you can see here that people really did feel like they made a lot of progress on all of the goals overall, but particularly on coping with stress, because only 15% said, a little progress here. And then again, we asked them how much of an impact working on the goal, how much of an impact did working on the goal have on them? And was it a big impact, medium impact, small impact, or no impact? And again, almost everyone said that coping with stress had a big or a medium impact for them. But, pretty much every goal that people worked on, they said, for the majority of folks said they were positively impacted. And then lastly, we asked, did working on this goal impact your family? Because of course, we're not just interested in their own impacts. And part of the goal of the program was really helping people to see and notice links between their own health and that of their family. And as you can see, people said that working on healthy eating made the biggest impact on their family, but also, again, working on their own stress management helped their families out a lot. Working on physical activity goals had a small or no impact on people's family for about 30% of people. And then we also asked people to write open-ended responses of how working on each goal impacted them and their families. And this is what they had to say. Now, most of these quotes have been translated. So if they don't sound quite right, that's probably why. They probably lose something in the translation. It helped somebody who was talking about their goal related to coping with stress said it helped me understand that I cannot control everything, and that's okay. This person, in response to their tobacco goal, said, excellent, because I no longer smoke cigarettes and I feel really good. I should note here that there were 4 people who started out the program smoking cigarettes. One person, this person, I guess, quit smoking entirely. Another 2 people started on NRT, and one of whom was able to reduce her cigarette consumption quite significantly down to, I think, just 1 or maybe 2 per day. And the third also had started on NRT and was making some quit attempts. So that was sort of our outcomes of people who actually were tobacco users. And keep in mind too that none out of the 4 of them joined for tobacco cessation. That's not why they joined the program. They weren't thinking about tobacco use at all when they joined the program. And that's really tells us that the program was targeting those tobacco users that we were aiming to reach. This person said about their sleep, since I started to set a schedule in the house, everyone is resting more. I feel like my brain is rested and my days last longer. I've noticed better grades in my kids' school and we have more energy to work out. This person said, if I cook vegetables at least 2 times a week, I feel good. My son eats what I cook and he likes it a lot. We feel better about his health. Imagine that. At first, they laughed and joked about me exercising, and then they really started to get into it. They want to support me, so we're doing more activity as a family. Okay. And then after participants had finished the entire curriculum, we sent them an anonymous electronic feedback survey to try and get their opinions about their experiences in the program overall, things that inform not just program efficacy, but also program implementation, feasibility, logistics, things like that. You can see here that the sample size is reduced, so we certainly aren't getting feedback from everyone in the program. One of the reasons is that this population in general really struggled with online surveys. So we also conducted focus groups toward the end of the project with former RAISE participants, and the focus groups had a few goals. We wanted to allow people who are less comfortable with an online survey format a chance to share their experiences as well. We also wanted to solicit qualitative feedback on topics that we had already assessed quantitatively. So for example, behavior change and things that we've already been talking about. But we also wanted to solicit feedback on topics that were more difficult to assess with a structured quantitative surveys. So things like thoughts on the inclusion of tobacco as a topic in a program designed to address kind of whole health and wellness. So what I'm going to do is show a few items on the survey in a few different categories, along with the percentage of folks who said they either strongly agree or agree with this statement. And then I selected a quote from the focus groups that was kind of representative of some of those key themes identified from the focus groups themselves, but that also mirror the feedback that we received from the survey data. Okay, so this is kind of feedback overall. I'm glad I participated. Everybody said that. As a result of the program, I'm motivated to make healthy changes. My family will benefit because I participated, and I would recommend the program. High marks there. This is just a quote that I thought exemplified some overall thoughts about the program. I think one of the benefits was to learn from each other and create a community, because we would help each other, give each other advice, support each other. So giving each other motivation to continue as a community. And I feel like together we can just accomplish more and influence our families more. I was able to influence my family with these classes, like my nieces, nephews, children, and siblings, to do more physical activity, to eat healthier, simply create healthier habits overall. Social dynamics of the groups, how much they felt supported by the RAISE facilitator. At Sheridan, they loved the facilitator. They felt very supported by others in the group. And most of them felt like it was helpful to hear perspectives and ideas from other participants in the group. Not everybody, but most. This person said there was always a person that would give you advice or a technique on how to exercise and how to relieve stress, how to relax. It was all connected. There was always someone in the group that had advice that would help. Feedback on incentives. The gift cards that I received were a big part of why I chose to participate. Not many people agreed with that statement. Since we implemented the incentive structure, we really wanted to know if people thought that made a big difference. According to this survey data, the answer is no. In hindsight, people didn't think that the incentives made a big difference. I will note that many of the people who participated early on in this survey, or early on in the program, didn't do the survey. And so I think these data are more reflective of people who perhaps had already heard through word of mouth about the program and who would have maybe joined even if there had been no incentives. So I think, and the leadership also thought that the incentives were actually probably pretty important in terms of getting this off the ground for recruitment and marketing. And this person acknowledged, yeah, for me, the incentives were always so helpful. But even without them, it was a way for my family and I to feel well. I joined for my health. So acknowledging that the incentives were useful, but it's not why she joined. So feedback on the group activities, receiving a lot of practice in setting goals, learning things. I'm working on all the goals we've talked about. I worked on them with my family to make sure we were all trying to implement the new habits. And with every goal I set for myself, I always like to make sure that I'm the first one to implement the goal so that my family can see me do it. And then they can take me as an example. And then finally, we asked a lot about the virtual platform and people's experiences with technology. As I mentioned, this group really struggled with technology initially. And so we really wanted to know how this went for them. And ultimately, what I would say is that the technology piece allowed some people to participate who would not have been able to otherwise, and they acknowledged that. However, they still would have really loved to have been doing this in person. And even admitting that it might have meant they couldn't do it at all. I would have loved to do this in person because it would have been a great experience, but I'm also very grateful that we were able to do it online because I would not have been able to participate if it was in person because of my work schedule. So I do think we were able to reach a number of people that we would not have been able to reach otherwise. As hard as it was for the facilitator to help these women get on Zoom, this was not something they had done before for the most part. All right, and then just a few other focus group things that emerged. Not surprisingly, the primary motivation for joining the group was ensuring a healthy future for oneself and one's family. And as well, connections fostered during the group may continue to flourish after the program. We heard from some people that they, were meeting up outside of group and doing things like a walking group and other kinds of activities. And so that was really nice to see as well. And then for this particular group, smoking was really normalized in participants' culture. And they had a lot to say about that. I've never liked the smell of cigarettes, even though our culture teaches that it's okay. I've seen how much our culture normalizes it because I've heard elderly men talk about how they started smoking when they were 10 or 12 years old, and they say it proudly. I think that it is really important that we learn about it so we can tell those that we love and teach them that they should not smoke cigarettes. So she's reflecting on the fact that even though nobody in her family smokes, they really feel like it should be more of a discussion to be included with other discussions of health. All right, and now I just want to spend the last little chunk of time talking about matters related to implementation. The initial results I've presented are positive, and I think they suggest that, as I said, better studies of effectiveness would be really beneficial. But we also know that regardless of whether a program turns out to be effective, none of that matters if the people it's targeting can't or won't access it, if the agencies they frequent won't implement it or can't fund it, or if the programs are not ultimately sustainable. And one of the guiding principles of our work out in the community is that studies of program outcomes or effectiveness and studies of implementation feasibility should happen in tandem. We learn something about the program's effectiveness for a given population, but we also learn something about implementation with each project and partnership that we develop. Okay, reaching historically hesitant populations. We know that closing health disparity gaps is crucial, but programs need to be accessed most by populations that have been historically hesitant to receive these services. A relatively less effective program or service will ultimately have far greater impact if it's accessible. Implementing agencies here are key. And as I mentioned, Sheridan is a trusted integrative care clinic in an underserved community with prevalent disparities like childhood obesity and tobacco use, lack of preventative care utilization, barriers to access to care. In Larimer, the Matthews House and the Center for Family Outreach are also trusted hubs of care and service for families in North Colorado who are struggling with poverty, abuse, substance use, and family conflict. So, and all of these agencies have really strong connections with other organizations in their communities, which we leveraged throughout the program. Sheridan runs a school-based clinic in the community and an early child care center. They also provide health care to people served by the CU's Addiction Research and Treatment Services, which is located nearby. Our project benefited from these and other connections. The agencies in Larimer also had numerous, connections with other social service organizations throughout Fort Collins, which they leveraged when it came time for marketing the programs up north as well. We've already talked about offering programming that's tailored to the populations that you're trying to reach. And of course, it also needs to acknowledge and target appropriate levels of health literacy. Being flexible with logistics is important. So from the patient or client perspective, the more flexibility that's offered within the bounds of what a clinic can accommodate, the better. So time of day, in-person versus virtual platforms. Of course, accommodating non-English speakers was key for Sheridan. Most of the groups were actually facilitated in Spanish, whereas this wasn't as crucial for our Larimer sites. And then finally, implementing a virtual platform in a non-technology savvy population does require accommodations and sometimes internet training sessions prior to program initiation. And I should have also mentioned that lots of what I'm talking about here in this last section with sort of implementing this program and addressing challenges and finding solutions. This is based not just on, our experiences, my experiences having run these programs or been a part of these programs for the last few years, but also from key informant interviews that we conducted with all of the facilitators at all of the sites, and also all of the executive leadership from all of the different sites. So I've kind of summarized a lot of the key takeaways and themes from all of those interviews, in addition to our own thoughts here. So when it comes to integrating the program into clinical workflows, there are a lot of things to consider and they're all really agency specific. So top of the list, not surprisingly, is personnel. But while it's obvious that the personnel required to facilitate the groups will be needed, it's a little bit less obvious to consider the additional administrative time required, which is not insignificant. And that was something that all of our sites struggled with at least a little bit, but our two social service agencies in Larimer in particular struggled with the administrative burden of running the program. One lesson from Sheridan was that staff who are dedicated to the programming need to have supervisors who are also dedicated to the programming. Otherwise, it becomes difficult for those staff members to carve out time. So Sheridan was initially going to have two facilitators, but our key program champion, the behavioral health director, only supervised one of them. And that meant that the other facilitator was really never able to link into the program. Communicating new initiatives across an agency was really important. So having a way to let staff know what's going on, even if they're not involved directly, that needs to happen fairly frequently. At Sheridan, providers served as a referral source for the program. So everyone needed to have the program top of their mind for referring their patients. And that communication piece does take work. The benefit of that, which was noted by the behavioral health director, was that the extra communication brought about by the new programming increased cross-disciplinary activity and coordination among Sheridan's different sites. So that was a positive that came from just having to bolster that communication. Our other two Larimer sites already had lots of communication with each other because they're very similar social service agencies working in the same locale. But they were able to learn and collaborate with each other while troubleshooting issues around recruitment and implementation. And then flexibility shows up here too. It's important on the patient side, but it's important from a clinic workflow side as well. RAISE is designed to be flexibly implemented depending on an organization's needs. Sheridan ran both one-on-one sessions and also group-based sessions. Larimer ran both in-person groups and also virtual groups, depending on their needs at the time. In the case of Larimer, we actually shortened the curriculum down to 5 weeks for at least one of their groups. And the lesson we learned there was that actually no one ultimately liked it very much. So which brings me to the final lesson on this slide, which is that some flexibility is good, but too much is bad. So developing a standard operating procedure does help agencies to know sort of what the boundaries are, what aspects of a program implementation and evaluation are negotiable or flexible, and which are not. Okay, so we've discussed already that recruitment was difficult, particularly at Sheridan, and we went over what the process looked like. But the lessons for Sheridan were to err on the side of inclusivity when making programmatic decisions on who your program is for. Clinics and agencies like as few decision points as possible. And in the case of Sheridan, we found out that providers simply didn't like having to establish whether or not someone had young kids in the home, or whether someone in the home used tobacco before referring them to the program. And so they simply weren't doing it until we broadened the eligibility criteria. Incentives can be expensive, but at Sheridan, we do think they made a difference in getting those initial people through the door. Once people had good experiences, they brought those experiences back to their providers, and some of whom became really reliable sources of referrals as and also word of mouth spread throughout the community. So by the end of the demonstration project, some of the last groups run had over 10 participants, and no recruiting or marketing was necessary at all for those groups. And I think that speaks to the power of word of mouth once something gets off the ground. And in the case of Larimer, those two agencies were able to leverage existing groups that were already ongoing, which was a huge help initially. So they run something called the Parent Cafe, which are groups designed to foster supportive discussions around challenges and victories of raising a family. And these were already happening, and they were a really natural way to integrate Raise Families for Health programming. They also express some recruitment challenges, but theirs happened a little bit later. And then let's see here. Finally, everyone across all the sites universally felt that establishing a trusting relationship between facilitators and providers does lead to participant engagement and appreciation. And this is something that, of course, all three sites had already done it really exceptionally well. Okay, and of course, everyone thought that, including leadership and participants, felt like the virtual programming helped with recruitment as well. All right, realistic, low burden evaluation. We've only got another, minute. So I'm just gonna briefly touch on the last couple of slides, and then I will end. The culture of data is important, and really the cartoon, I think, almost sums up everything, which is that you have to be realistic and flexible when setting up your evaluation. However, it is important to communicate why it's important for future funding. And I would also just add that you might consider incentivizing evaluation activities in addition to the actual programmatic activities. Attending to billing early on in the partnership development phase is crucial, and assessing who the implementing agency's funders are. And finally, there are several outlets that we've already discussed for maintaining a trained workforce, like an academic pipeline. If billing goes well, then agencies can do this themselves, and peer specialists are another good cost-effective model for maintaining a trained workforce. And this is my last slide. I'm just gonna leave you with this final quote, and I appreciate everybody attending today. And I will stay on for an extra few minutes to try to address some of the questions in the chat if anybody has time. And I'll end